Good morning, good afternoon, all of you. This is Robin Elliott, President of the Parkinson's Disease Foundation, welcoming you to what's, I think, the fourth talk in our seventh series of PD Expert Briefings. Our title today, as you all know, is Dealing with Dementia and Parkinson's Disease, and we're just delighted to be able to welcome one of our scientists from Rush University in Chicago, one of the institutions that's very close to my own foundation. It's a research center of excellence, has been for well over a decade. Our speaker is Dr. Jennifer Goldman. She's an associate professor of the section of Parkinson's disease and movement disorders at the Department of Neurological Sciences at Rush University, and she is a movement disorder specialist with a focus in her research on the issue of cognitive and behavioral issues in Parkinson's and the mechanisms, biological mechanisms that underlie those, and then how to treat them. So she's wonderfully qualified for this very important subject. I told her, and I asked her to promise not to be too nervous about it, that she has almost a record audience for this talk. Not surprising given the intensity of questions and challenges in so many families. More than 1,400 people are joining us either today or in the course of the next few days. So, and we'll give many of those an opportunity, as you know, if you attended the series in the past, to ask questions for the last 20 minutes or 25 minutes of the session. If we cannot get to your question, forgive us. We'll try and find a way through our helpline to do so afterwards. So don't feel defrauded if you find that we don't get through to you. We will do what we can in the time available. I want to acknowledge our co-sponsors for the session, a series of terrific independent Parkinson's organizations around the country. There are 7 or 8 of them, and I won't read the whole titles, but they come from places like Dallas, state of Michigan, the Carolinas, the Rockies, and the Kentuckiana, which is a new word to me, but it has to do with the state of Kentucky and places around it. And we welcome all of those as co-sponsors of the series to keep us honest and relevant in what we do. I also want to thank formally, with great gratitude, but with the same time affirming that they have no direct connection with the production here, 3 companies in the pharmaceutical industry who've lent their support as well as their enthusiasm for this series: AbbVie Pharmaceuticals, Acadia Pharmaceuticals, and Lundbeck, LLC. This series simply wouldn't be possible without their support, and we're very grateful for it, and grateful and want you to know that this too, though it's, of course, our work is entirely independent of anything they do in the drug industry. I want to just notify you, again, for those who are not regular customers to this series, that you can download the PowerPoint slide deck from the reminder email that you should have received this morning, or from the PDF web page that highlights this talk. So you have 2 choices there. I also want, as my final public service announcement, to inform those of you who are eligible for health profession-related continuing education units, or CEUs, that you are entitled to receive 1 free CEU through the American Society on Aging. I believe we have 300 or 400 of you on this call who came to us through that source, so you'll be particularly interested to know that there is credit given for your participation in this. And if you will receive an email by the end of today with steps on how you can collect your CEU, and then we warn you have just 30 days until March 31 to collect the free CEU. So without further ado, my great pleasure to introduce our guest speaker, Jennifer Goldman. I've told you where she is and what she does and what her interest is, and we are just thrilled, Jennifer, to welcome you to this discussion today. You'll be speaking, I believe, for around 30 minutes, maybe a bit longer than that, and then we'll open the floor to questions. So if you have questions, I was told that several of you, maybe several dozen of you, had already sent your questions before the thing started. But if you do think of one during Dr. Goldman's talk, do let us know. We have 2, I guess now 3 of my colleagues here who will be taking them down, passing them to me, and then I will combine them in some appropriate way and ask Dr. Goldman the questions after her talk. Once again, Dr. Goldman, thank you for honoring us with your presence, and the floor is yours.
Thank you so much, Robin. It's my pleasure to be here, and thank you to the PDF for inviting me to speak with all of you and share some insights and work related to dementia and Parkinson's disease. So greetings from snowy Chicago right now. And we are going to spend the next bit of time talking about a topic that is so important but also really scary for a lot of people, either because they have Parkinson's or they live with someone or know someone who has Parkinson's. But it just shows that with the volume of people on the call and attending, how important it is to educate ourselves about this, to understand and to learn what we can do about dealing with dementia and Parkinson's. So the talk is divided into 3 areas, and these are the objectives, and certainly for those of you who might be obtaining continuing education credits. We're going to first go over some of the clinical symptoms and current research on risks and causes of dementia and Parkinson's. Then I'll talk a bit about some treatment and management strategies. And then lastly, some practical tips and resources for people with Parkinson's and their care partners, as well as healthcare professionals who may encounter patients with Parkinson's as well. So first, to talk about some of the clinical symptoms, risks, and causes. It's important to first recognize that the spectrum of cognitive impairment in Parkinson's is quite broad, and this occurs in a number of different dimensions. So first, there's a broad range of severity of symptoms. It's been thought that PD cognitive impairment ranges from very mild slowness of thought, which was once coined the term bradykrineia many years ago. And this is actually similar in concept to bradykinesia, which might be a more familiar term to patients and practitioners, which is one of the hallmarks for the motor signs of Parkinson's, or when movements and walking get slower. So this manifests as very mild or slowed thinking processes, not being as quick to come up with thoughts or process information. The concept of mild cognitive impairment, which is also called MCI, and you may hear or see that abbreviation, is an entity that's become increasingly recognized in Parkinson's over the last several years. And some of this has come from our understanding of aging and its progression in some patients to Alzheimer's, and having an intermediate step where there may be mild symptoms but that don't quite meet the symptoms for dementia. And in the Parkinson's field, we've sort of borrowed this as a concept to understand when patients have mild difficulties, but yet they are not significantly impacting one's daily activities of living or one's daily function. In many cases, MCI, or mild cognitive impairment, can be a precursor to a more severe form of cognitive impairment known as dementia, but this is not always the case. And many patients who have mild symptoms may remain with mild symptoms for many years. We'll talk a bit more in detail on dementia, but we reserve this term for when cognitive deficits become more severe and have a significant impact on activities of daily living. The spectrum of cognitive impairment is also broad in its clinical features, and although it's frequently thought, when people say they're having cognitive troubles, it's frequently associated with, oh, my memory is bad, or it's focused on memory. But in all reality, there are many different types of cognitive domains and cognitive features. And we'll talk a little bit about these in greater detail. And we know that memory may be affected in Parkinson's, but it's not the only cognitive area. Some patients have greater trouble with attention or executive function, and it's important to recognize that different cognitive domains can be affected in Parkinson's. Some patients may only have one area that's affected, and others may have multiple as well. In terms of diagnosing cognitive problems in Parkinson's, it's helpful to understand how a healthcare professional might think about these when seeing a patient in a clinic. The information can come from many different sources, including the patient themselves, who may report changes in their thinking abilities. The information can also come from what's known as an informant, and these are usually the family members, a spouse, friend, or caregiver who has noticed some changes in the patient's thinking. In addition, the clinician might observe changes as well. While this subjective information is very helpful, and especially to start a dialogue with one's healthcare provider if there are cognitive concerns, and to figure out the next steps and plan any evaluation and management, there is a role for objective evidence or tests. Some of these tests range from very quick, short bedside tests that can be done right in the clinic or at the bedside, which is termed usually coming from inpatient assessments that assess global cognition, so a little bit of every facet of cognition. They range from that to comprehensive detailed testing, usually done by a neuropsychologist that taps into multiple different areas of cognition and sometimes can last about 2 or 3 hours for testing. In addition, in recent years, there have been some diagnostic criteria, mainly for clinicians and for research efforts. Some of these efforts have been led by the Movement Disorder Society task forces for Parkinson's dementia and Parkinson's mild cognitive impairment, or MCI, and really have helped our field be able to identify patients and be able to use these criteria in clinical trials for new medicines. So I want to talk a little bit about some of the cognitive features that we see in Parkinson's and each of those cognitive domains that could be potentially affected. So mild cognitive complaints are actually quite common. And in recent years, this recognition of non-motor and cognitive issues has grown tremendously, as we can see by the evidence of today's webinar. Some of these include slower thinking. Things just don't come as quickly as they used to, which is something that also can happen with aging as well, or other elements like lack of sleep, or sometimes with medications. Other cognitive features that can occur in Parkinson's are focused on an area called executive dysfunction. And these have to do with difficulties with planning or organizing, problem solving, or what we call multitasking, which is doing multiple activities at once, such as reading or talking or looking at one's email and so forth. Patients may also have trouble shifting between tasks. So once they start something, it might be hard to go to the next one. People may also report decreased attention or concentration, such as when reading or in conversation. There are also several other cognitive features that we see in Parkinson's, and some of these affect memory. I mentioned before that many of these, when we think about cognition, many people associate that with memory, but memory is really, as you can see, only one facet of cognition. The difficulties that we see for memory generally involve short-term memory. So the details of something from the day before, or the movie someone saw last week, or what they might have had for dinner, those sorts of short-term memory occurrences. And this is generally a problem with the retrieval of the information rather than the encoding in the brain or the storage of information. It's kind of like the computer processing is slower, and it's harder to find the files one needs to use. Interestingly, in Parkinson's, recall generally improves when people are given cues, and this can be a very helpful strategy in conversation with people with Parkinson's. So the information's there, you just have to find the right cue or hint or choice to get at it. Generally, long-term memory, such as dates, where one grew up or what year someone got married, is usually fine. Some patients may have trouble with visual spatial function, such as having an impaired sense of direction or getting turned around in one's environment. And of language, the most frequently encountered finding is trouble finding the right words, or what we call decreased verbal fluency. So those are some of the different types of cognitive areas that we can see in Parkinson's. And this is not to say that we see this in every patient, and we might see some in some patients or none at all, or some combination of these cognitive domains affected. And in terms of our understanding and research, we know that different parts of the brain can be affected. And that's because different areas of the brain are actually involved in these cognitive domains. So we can link parts of the brain to the behaviors we actually see in the clinic. And so here in this table are listed 5 commonly described cognitive domains: attention and working memory. And working memory is the capacity of keeping items in one's head while doing something else. So such as trying to remember a telephone number while one is talking to a person or reading a paper, and then going back to remember that telephone number. The others I mentioned before include executive function, language, memory, and visual spatial function. And here you can see that there are different elements of the areas of the brain that are affected and really govern these cognitive areas. Here you can see this is an MRI scan of a brain, just highlighting the different regions. And some of these areas, like the prefrontal cortex or basal ganglia, are very important in Parkinson's and involve some of the chemicals associated with Parkinson's, such as dopamine. Our understanding of what we call the neuroanatomy of cognitive function has led to research advances, such as with imaging biomarkers, to understand what actually happens in the brain. So we can study the size and the shape of these different structures. We can look to see if they are atrophied or they look the same, or whether they connect to other areas of the brain in the same way that they would if one was not having cognitive difficulty. So in terms of cognitive impairment, specifically in Parkinson's, the frequency of this varies quite a bit in the literature. And this may depend on all sorts of factors. So from where the studies were done, whether they were done in large communities, the geographical region, whether they were done at academic medical centers like Rush or others, what kind of tests were used, whether their patients were newly diagnosed and more advanced. So these are estimates, and that's always important to remember, because some of these estimates seem like their numbers are large, but some of that might be determined by the population that was studied. So always important to keep that in mind. So looking at some of the studies of how frequent mild cognitive impairment could be, people have quoted about 20 to even up to 50% of people, and these are mild symptoms. We've also learned that trouble with thinking in Parkinson's is not something that we need to wait many years to ask about, but we should be asking patients about this early, because some of the patients may have early mild changes, and some of these might actually respond to medicines for treating the Parkinson's. Some of those include decreased attention or concentration or executive function, and might improve with dopamine medications. From some studies, it's been reported that about 40% might have more severe deficits, and this might increase with longer standing or more advanced Parkinson's. But I think the most important take-home point as well is to note that not every person with Parkinson's develops cognitive impairment or dementia. And we know Parkinson's is very individually variable, and not everyone will experience these symptoms, but even just by educating oneself on them and helping research efforts, hopefully we can prevent them in the future. And I think we can learn a lot, too, from people who don't experience cognitive changes, because why some people are protected is also important. And I think that's important in aging as well. Why do some people age differently than others? So let's talk a little bit about what is dementia and Parkinson's. So this is often, as I mentioned, a very, very scary term, but it has some unique features to Parkinson's and some very specific definitions. And so this slide comes from the Movement Disorder Society criteria that were published in 2007. And so dementia is a syndrome with gradual onset and slow progression. It occurs in the context of Parkinson's disease. And this was important to help establish that these problems are different from other dementias like Alzheimer's, which is a different condition. It's important to recognize that this is slow and gradual, and this does not happen overnight. By definition, dementia includes a syndrome that has impairment in more than one of those cognitive domains that I mentioned, and it represents a decline from where someone was in their previous experience or year before or several years before, with deficits that actually have an impact on activities of daily living. And those are tasks like paying the bills, grocery shopping, dressing, bathing, etc. It occurs in the context of Parkinson's, and these impact on daily life is due to cognitive features and independent of motor symptoms, which can actually be a really tricky thing to try to sort out. Another thing that we've learned in Parkinson's that might make it different from Alzheimer's is that memory is not always the problem, and there may be other cognitive deficits affecting executive function or attention that come about. We also know that behavioral symptoms can be quite common, and these include changes such as apathy, mood with depression or anxiety, hallucinations or delusions called psychosis, or sleepiness. And so it's important to recognize some of these other non-motor features as well. One question that frequently comes up is, how does Parkinson's dementia differ from Alzheimer's or another condition that people may have heard about called dementia with Lewy bodies? And in fact, Parkinson's dementia and dementia with Lewy bodies, not to make it confusing, but both fall under an umbrella term called Lewy body disorders or Lewy body dementias. So that is something you might hear about or read about in the literature. In this table, you can see some of the key clinical differences outlined, and just to highlight a few, here one of the clinical anchors depends on the timing of the cognitive difficulties. So when we see them in Parkinson's, they're usually later. So someone may have motor features first, and then more than 1 year and years down the road, cognitive symptoms or dementia. Whereas in Alzheimer's, that's the primary feature, and that's the early feature. And in dementia with Lewy bodies, it is also earlier and typically before there are motor symptoms. As I mentioned before, the profile of cognitive symptoms differs across these groups, with memory being the hallmark of Alzheimer's disease. In Parkinson's, obviously, we see Parkinsonian motor signs, whereas we might not see those in the other conditions. Similarly, hallucinations, which is a topic for another session, I'm sure, may be seen along with Parkinson's cognitive symptoms, but is rare in Alzheimer's and much more common in dementia with Lewy bodies, particularly early on. And similarly with fluctuations in someone's cognition or consciousness throughout the day. Since this question frequently comes up, just to highlight the key difference in sequences and how we might think about this clinically is the timing and the relative proportion of motor and cognitive symptoms, with Parkinson's having early motor, as you can see in the blue, and later cognitive to the degree of dementia, where it's almost the reverse sequence, if you will, in dementia with Lewy bodies. And this has raised the question that could this, as you can see on the right bottom picture from Brock's pathological staging, might reflect different areas of the brain and how they're affected in the time course of when they're affected. And this is just a picture of looking at different regions of the brain. It's raised the question whether these two entities are two sides of the same coin. And much work has been done, and much work needs to be done in biomarker studies to understand, are there differences in brain imaging, biological changes, or genetics, so we can understand the neurobiological differences or similarities of these conditions. So one fundamental question is, why does Parkinson's cognitive changes or dementia occur? And there are a number of theories. So one of the reasons may be that Lewy bodies, which are made up of alpha-synuclein that forms protein clumps or aggregates, can form in key regions of the brain that are involved in cognition. Some of those areas that were highlighted in the slide previously or in the brain scan slide. And these might involve areas involved in thinking and memory. There may also be a decrease or loss of key neurotransmitters involved in cognition. Several of these are listed here: acetylcholine, dopamine, norepinephrine, and serotonin. And although we typically think of Parkinson's as related to dopamine, what we've learned over the years is that many of the non-motor features, and even some of the motor features as well, are very, very much related to these other neurotransmitters. And in fact, these other neurotransmitters form the basis of some of the medicines to treat cognitive issues. There may be also some patients who have coexisting Alzheimer's disease changes in the brain, and that's because one of the biggest risk factors for dementia, as well as Alzheimer's and Parkinson's, is aging. And so when people get older, sometimes we find these protein clumps in autopsy studies looking at brain tissue. In addition, there may be other coexisting changes in the brain that affect the vascular system or blood vessels. And these we can see sometimes on MRI brain scans or other neuroimaging techniques. So a great deal of research has been focused on detecting markers for Parkinson's dementia, not only to understand why it occurs, but to have markers that can distinguish Parkinson's dementia or cognitive symptoms from other causes, and to identify changes early in patients who might be at risk for developing this, so we can have interventions to stop it or to halt and slow its decline. We need to have biomarkers to be able to identify targets for new drugs and development of therapies. So this is a diagram from a very nice review by Mollenhauer et al., published in 2014, that highlights some of the key proteins that I mentioned. So the Lewy body on the bottom, and the amyloid plaque and neurofibrillary tangle, most commonly associated with Alzheimer's disease. And here you can see that we can look at these in brain tissue on autopsy study, but also there's some imaging techniques that can at least look at amyloid plaque loads and another protein called tau, which makes up the neurofibrillary tangles, and potentially in the future being able to image alpha-synuclein related to the Lewy bodies. We can also measure some of these in cerebrospinal fluid with a lumbar puncture or spinal tap, and there's some differences that might help distinguish these different groups. This is right now done on a research study basis, but it might give us clues to have drug development targets or be able to predict who might be at highest risk for these cognitive symptoms. There are a number of possible risk factors. Now, these are quite varied in the literature and are rather mixed. Probably the biggest risk factor, unfortunately for all of this, is getting older. But we can't do too much about it, so we have to think about ways that we can all age successfully. So the top three are probably the most consistently reported in the literature, and those include older age, increased motor severity, and having cognitive impairment to start at the time of diagnosis or early on. The others listed are somewhat variable in the literature, but highlight the fact that this is something that doesn't necessarily occur early in Parkinson's, but with more long-standing duration. There's been some work and research done looking at different motor phenotypes, and this has raised the question whether there are differences in people who have a lot of tremor versus those who might have more trouble with balance and falls. Are there risk factors related to neuropsychiatric symptoms like hallucinations, mood, and sleep that I mentioned before? Some studies, including a very large study called the Campaign study from the United Kingdom, has proposed that certain cognitive deficits might be linked to higher rates of cognitive decline. And some of this work has proposed that differences in executive function, patients having that might be more stable over time, whereas those who have more memory or visual spatial impairment or trouble with certain types of verbal fluency might be more at risk for developing dementia. Some of those clinical features in the different cognitive types actually might be governed by people's genetics. And so we're learning quite a bit about the role of genetics and environment and how that might contribute to many symptoms of Parkinson's, not only cognitive, but other aspects as well. And there are certain genetic mutations that might be more linked to the development of cognitive and behavioral issues, and others that might be not. So one active area of research is to use these biomarkers and risk factors to try to identify early signs looking across the spectrum of cognition in Parkinson's. And as I mentioned before, and I just want to reiterate this point, is that not all patients with Parkinson's have cognitive symptoms. So as you can see here, there are patients with Parkinson's who have perfectly normal cognition. And then, as I mentioned before, I want to reiterate this point as well. There are some patients who may have mild difficulty, and they may stay with mild difficulty, or some of them even over time may revert to normal cognition, and in some they may progress to dementia. So this middle group may have a lot of variability. And one of the things that we are working in the field to understand is what can we do to modify and what contributes to the progression or the stability or the reversion across these cognitive categories, whether those are features related to our demographics, our age, our gender, things in our genes or environment, or certain clinical features. And are any of these risk factors modifiable, like lifestyle changes? So with that, I'm going to turn and talk about some of the treatment and management strategies for dementia and Parkinson's. So as I mentioned before, these changes don't happen overnight, and if something happens abruptly or acutely, it's worth looking at other causes because very frequently it is not related to the Parkinson's per se. And we know this for cognitive changes or acute onset of hallucinations. And one of the things that we look for are excluding other causes. So things such as a infection or a urinary tract infection, other medical illnesses, new medications, many different medical causes. So it's very, very important to always review one's medication list and to check with your doctor about drug interactions. There are numerous medicines that can cause cognitive side effects. Some of these could be pain medicines, medicines taken for sleep or bladder function, and even some Parkinson's medications. So we want to try to either avoid these or diagnose them if that is contributing to an acute cognitive change. On a more chronic front, one might consider prescribing medicine or participating in research studies. I'm going to talk about a little bit of those right now. So of the treatments for Parkinson's dementia, this has been largely based on the neurotransmitter called acetylcholine that I mentioned. And these drugs form the basis of cholinesterase inhibitors. There are 3 of them listed here. And this work really was pioneered in the field of Alzheimer's, but there is a role for potentially greater cholinergic deficits in Parkinson's dementia. So we've kind of borrowed them. And I need to note that the only one that is currently FDA approved for Parkinson's dementia is rivastigmine. Another category of medicines that have been studied are called NMDA antagonists, of which one is memantine, and that's been looked at in Parkinson's with some mixed results in large trials. So this has led to some work with new compounds to try to branch out for different neurotransmitters and to improve the effects of Parkinson's therapies. So with all these that are mentioned here on the slide, with rivastigmine being FDA approved, there have been beneficial effects reported, sometimes modest, but some noticeable in many patients. And these are usually things like attention or executive function, as well as potentially other areas, including benefits for hallucinations, gait, or falls. Generally, medications can be well tolerated. Sometimes there can be gastrointestinal side effects such as nausea or diarrhea, and these would be medicines for discussion with one's individual physician. There are currently a few medications and other therapies under study. One is the SYNAPSE trial, which is a new study for Parkinson's dementia that is underway and recruiting across multiple sites in the United States. It's funded by a company called Biotie and the Michael J. Fox Foundation as well. And this is an interesting compound because it works on the serotonin system, and it's being compared to placebo in this trial in terms of its effects on cognitive tasks. And the serotonin system is highly involved in cognition and behavior, and it's interesting that there are many serotonin receptors in areas of the brain that we pointed out on those other slides that are involved in cognition. It's shown some promise in animal models and other dementias, particularly with cholinesterase inhibitors as a synergistic effect. Nilotinib received a lot of attention earlier this year for a phase 1 pilot study done out of Georgetown. This was a very small open-label study of about 12 patients, and this is a chemotherapy drug used for leukemia that may have a role in what's called autophagy, or clearing out cells that shouldn't be there, or proteins that shouldn't be there, such as related to alpha-synuclein. So these positive results were encouraging, but it's a very small study, and at this point further studies would be needed. Several groups have also explored the role of deep brain stimulation for non-motor symptoms, stimulating areas of the brain that are involved in cognitive circuitry. And there is growing work looking at neuromodulation techniques with transcranial magnetic stimulation and stimulating areas for both cognition as well as mood improvement. Most of these studies are primarily in pilot stages at this point. And as well, there's a growing field of lifestyle modifications, those involving the effects of physical exercise, cognitive training with pen and paper or computerized programs on cognition in Parkinson's. While we have a long way to go, while we have come a long way, there is still a long way to go. And this just highlights a few areas that we need to cover in the field in the future. While we've recognized that cognitive issues are a problem and there's great attention to these, we need to improve our understanding of why people develop them and identify people who are at risk. We really need to develop drugs and interventions to slow down or stop these symptoms, as well as many of the other Parkinson's symptoms. We've come very far, but there's more to go. We need to intervene early before there is dementia present. We need to even improve cognitive symptoms when they are present. We need to be able to help patients and caregivers alike. So with that, I'll turn to the last part of my presentation with a few practical tips for people with Parkinson's and their caregivers when dealing with some of these cognitive issues. So the first area is communication, and probably communication and patience are essential and key. And some suggestions are to show rather than to tell someone something, and we try to do this in many of our clinic visits. But the other is to don't show and tell at the same time because there can be problems with multitasking. It's important to get the person's attention before asking a question and trying to maintain attention while talking with someone. Eye contact can be helpful for that. Using simple language and being specific can often be very helpful in giving choices rather than open-ended questions. And this goes back to the earlier statement that I made that recall can sometimes be very well intact, whereas it might be a hard time retrieving the information, but given the hints or clues, the information pops up. And of course, speaking clearly and slowly and being patient. In regards to appointments, it is always helpful to have another pair of ears and eyes at one's physician's appointment. I encourage people to keep appointment reminders, the cards that they get from the office, to write things down on a calendar or use a device to remember key things, not only appointments, but other social dates and family events. It may be helpful to do some preparation for one's appointment. So for the person with Parkinson's to talk with their family member or whoever's coming to the appointment about some key issues that they want covered during that appointment, and for someone to write them down. This can be helpful for setting priorities and taking the time to figure out what are the key areas that should be addressed. It may be helpful to keep a folder of important medical information handy, imaging studies, blood work, and so forth, and then to ask questions to make sure it's understood. And of course, in terms of medications, our patients can be on many different pills and complicated regimens, so this can be a big challenge. But there are many different types of pill boxes and alarms and watches that are readily available. Other strategies include not trying to multitask and trying to simplify the environment and declutter areas around the home. Even if one is retired and at home, it may be helpful to keep track of the calendar and current events. It may be helpful to make lists of items, and it's important to maintain a regular routine, and that goes for sleep hygiene, exercise, and eating as well. There's been a large body of work looking at socialization, and that's helping with healthy cognitive aging. So recruiting friends and family into the process can be very helpful. It's important to talk about some safety issues, whether those include driving or safety around the home or medication management, as well as planning for financial needs, care needs, and wishes of the person. And then finding what resources are available, whether it's webinars like these or community resources, local chapters, other organizations that deal with dementia for Alzheimer's or Lewy Body Dementia Association, locally in the community or online. And so it really takes a team approach, and that team includes the patient and the caregiver. And so with that, I will close and thank you for your attention, and I think we'll have some time for questions.
Really, absolutely terrific, Dr. Goldman. Thank you so much. So clear and so complete. If I had teachers at my university which were as good as you, maybe I'd have got a few more A's under my belt. One of the problems of being as good as your talk was is that you ate up many of the questions that we got before the talk because you pressed all the right buttons. So some of our people who ask questions will have already found them answered, and so we are now left remaining those that are particularly challenging, including a couple of words I couldn't even understand. So we'll try those on you in a second. For those of you who do have additional questions to raise, do feel free to ask them now, and if we don't have time now to answer them, we'll do it later. You click in the text box, enter your question, and then click the send button. It's pretty straightforward, and most of you have done this before, but do keep them coming if you wish. And meanwhile, let's get back to a few we'd like to ask Dr. Goldman. Now, here's a pretty straightforward, and I think you didn't answer this. And it has to do with whether gender, which has accounts for so many differences in medical life, whether there's a difference in incidence and prevalence of dementia by gender.
So thank you for the questions. And the issue of gender in terms of dementia is a growing area and really quite a current and timely topic. And it's interesting to think that in Parkinson's itself, we see, so not talking about cognition at all, but just talking about Parkinson's, we see a bit higher ratio of men to women. That quotes about 1.5 times men being affected than women. And if you look at another disorder, Alzheimer's, actually you might see a little bit of the opposite trend with women. And some of that might have to do with longevity. Studies suggesting women could live longer. So I think in terms of understanding the role of gender in Parkinson's dementia, we have a lot to learn. So are there protective effects related to estrogen or hormonal influences? There's some uncharted and important territory there.
Thank you very much. Here we have a question from Massachusetts, and it's about antibiotics. This person, Dr. Goldman, has read an article recently. You've got a very brainy group on the phone today, and we all read a lot. This person has found an article which indicates that antibiotics can, in some cases, impact cognitive function negatively. This person is worried because her husband uses antibiotics and wonders if you have any advice on that score.
Sure. So antibiotics are another type of medicine, and one needs to keep those in mind when reviewing the whole medicine list. Actually, certain antibiotics can affect different parts of the system. Often we think of just the GI tract and then making us feel nauseous or have GI distress. But there are some that can impact cognition or behavior, usually on an acute basis. With that said, it's also important to recognize that the infection itself can also impact someone's cognition and behavior in a short-term basis. And we know this, as I mentioned a little bit before, that when someone calls or comes in the clinic and they're having an acute period of being confused or worse cognition or worse motor function or new onset or worse hallucinations, very often that might actually be due to an underlying infection, such as a urinary tract infection or a pneumonia. So it can be hard to separate what's related to the infection itself or the antibiotics. And usually those are acute and temporary type changes.
Thank you. While we're on the subject of medications, you have a question from Pennsylvania in which our questioner is asking whether a particular drug, which I frankly hadn't heard of, is Risperidone, I'm told is an antipsychotic, whether the use of that particular medicine can, in your view, can exacerbate dementia.
So Risperidone is, as you mentioned, a medicine that falls under antipsychotics and has some properties that are used to treat behavioral issues or actually psychiatric issues. Risperidone itself, we would not expect to have that effect on cognition, but it is an important medicine to understand in Parkinson's patients because it blocks dopamine. So it does the opposite of what we aim to achieve with levodopa. So it would be worth speaking with one's physician about the use of this medication.
Thank you very much. And from medicine to surgery, you touched on this, Dr. Goldman, but a couple of our questioners would like a little more depth on it. The matter of deep brain stimulation, a very commonly used surgery in Parkinson's, and whether, in your view, this is from Colorado, the question comes from, whether DBS can exacerbate or speed up either the risk or the progression of Parkinson's symptoms? Of dementia symptoms. I got that wrong. The dementia symptoms, are they exacerbated or accelerated by the use of DBS?
Yeah, so deep brain stimulation has been predominantly used for the motor symptoms in Parkinson's, treating tremor, motor symptoms, helping people with dyskinesias and so forth. And because of that, because of the stimulation procedures, over the years we've been able to learn a bit about what happens to non-motor features, including thinking and memory and emotion and so forth, not only from Parkinson's but also from a growing field of deep brain stimulation in psychiatric conditions. And some large studies have suggested that depending on what area of the brain is stimulated in Parkinson's, usually the subthalamic nucleus or the globus pallidum, that can have potentially some different effects on cognition, although I think much more study needs to be done in terms of working that out. So while we wouldn't think that it exacerbates it or aggravates it, there can be some different findings on neuropsychological tests depending on which area is stimulated. And so this is an area that is being further studied so that we can be able to counsel patients appropriately and look at the best candidates and areas for stimulation. And there's a growing interest in, from some of these pilot studies, stimulating areas of the brain that are involved in cognition and mood for other reasons. So that's potential therapeutic help.
Thank you very much. This next question, which is a very down-to-earth one, it's asked by a person in Pennsylvania. I'm sure it reflects questions among maybe hundreds of people on this call, is the matter of care partners. And what you would advise as a physician, but you also see life in many, many complexities, how you would advise a care partner with a partner with Parkinson's who appears to be exhibiting what she or he thinks are some signs of cognitive decline. Are there any tips that you would have for the care partner in advising, helping, referring, caring for, consoling the person who they live with who seems to be exhibiting symptoms of this kind?
Sure. That's a great question. So probably the first step would be to talk about it and try to understand what's going on both in the home, but also with one's physician. I think it's really helpful to have an open dialogue about some of these issues, because all too often they're actually not discussed or not brought to medical attention until things are more advanced. There are other reasons people can have cognitive symptoms, which is perhaps another topic unto itself, that relate to medical conditions or medical illnesses or vitamin deficiencies or changes that might need to be excluded. So having one's doctor as a partner in this would be very helpful. And there can be other evaluations done to gauge the extent of it and its impact. So I think those can be helpful, as well as talking with people, either whether it's in support groups or local resources or online. More and more I realize that this is common symptoms, and asking patients about that, even when whether mild or more impacting, can be present and represent a change, and something that we can work with patients and families on helping them and help with the various treatments.
Thank you very much. We had a couple of questions concerning potential interventions that you did not mention, perhaps because they're not worth mentioning. One of them comes from an allied health professional from Fort Worth in Texas, and the other from a person in New York City. From Texas, we have the question about coenzyme Q10 and whether this can have any impact upon dementia or cognitive decline one way or the other. And the other, maybe asked by a presidential candidate in the current race about New York lifestyle, this comes from New York, is cannabis or marijuana beneficial for dementia and Parkinson's? Coenzyme Q10 and marijuana.
Okay. So the story of coenzyme Q10 has been sort of near and dear towards Parkinson's for many years. It has not really been looked at in terms of the cognitive symptoms per se, but it had some promise on a smaller study for motor symptoms and progression of Parkinson's that unfortunately did not pan out in a much larger trial. So that has somewhat faded away in that capacity. But I can't comment on its effect on the dementia aspect. In terms of cannabis, I think this is definitely a growing area in medicine that we really don't know enough about in terms of its role in diseases or disorders. There is also evidence of cannabis, marijuana, negatively impacting cognition, so it's something that one would need to be very careful about.
Thank you very much. I've got, let's see now, where shall we turn here? There's a general question raised in New York. Actually, it's several people asked this question, I'm told. And then another person from Minnesota had a very specific application of it. The matter of aggressiveness and violence, agitation, that are not themselves dementia as we understand that word, but may be associated with it. What is, in your view, is the relevance, prevalence of this? Is it a serious thing? Is it related to dementia? When people become aggressive, even in the one case from Minnesota, literally violent, which must be completely terrifying. Do you have any tips on how to deal with it? First of all, is it related to cognitive decline in any way, or is it related or unrelated? Are there any pieces of advice you might give to the care partner in a situation like that?
Mm-hmm. So agitation is not that common that we see in Parkinson's and in dementia as well. But when it occurs, of course, it can be very frightful and definitely have an impact on caregiver and patient and their relationship. But it's not a very common scenario. And there may be other reasons that are involved in agitation. Sometimes this can be confusion, disturbances of not fully appreciating one's surroundings, or not being able to express oneself and their wishes. And it's sort of hard to know exactly what triggers it or what's going on. It can be coupled with very advanced cognitive symptoms, and sometimes in the setting also of psychosis or hallucinations or false beliefs or delusions. There are some tips, in terms of dealing with when people are agitated, and that's to try to provide a very calming environment and to work with them through this, work with other allied health professionals, caregivers, support, psychiatry if needed, both on non-pharmacological or even with medications if needed. But again, this is something that does occur, but it's not a common occurrence.
Very much. I think we have time for just one more question, and we are leaving several on the shelf, so we'll find a way to get information to you. My immediate suggestion is that you call our telephone number and our helpline and refer your question there, and one of our very capable professionals on that line will help you with. I'm sorry we couldn't get through everything, but it's not surprising given the importance of this talk and the number of people on the call. My one choice for this final question I make because of all the things that in Parkinson's, for various reasons, trouble families and couples. Driving a car is usually very high on the list. And this person from Pennsylvania is asking about whether this could have a cognitive, in addition to whatever motoric symptoms in Parkinson's that may cause problems with driving. Is there anything in the area of cognitive decline, reaction time? I'm not sure it's physical or emotional or mental, but do you have any comments on the issue we're talking about today and ability to drive a car?
Yes, driving is a very, very important consideration, not only from a cognitive perspective, but also, as you pointed out, Robin, and through this, from a motor standpoint. There's so much that goes into driving, vision, reaction time, neck mobility, getting in and out of the car, cognition, so many things. And it's a very important issue because we know it's associated with independence and ability to do things. So we take it very, very seriously, as well as safety and repercussions. So driving is one of those tricky issues. There are a number of ways to assess driving as well, and some states and places work with occupational therapy or driving programs to evaluate patients. And these range from all sorts of programs of being in someone's car or a mock demo car or even computerized simulations to get a sense of what it's like to what sorts of problems might be occurring with driving and what conditions one might be able to drive in, or whether one is not safe to drive. So this is an important topic, and even potentially working with rehabilitation specialists to come up with strategies that can help not only in driving, organizing, and planning, but ways to help with cognition overall.
Thank you very, very much. This is just terrific. I'd love to keep you on the phone another half an hour, but I'm not going to, out of respect both for you, certainly, but also many others on this call who have many other things in their lives too. But it was just a terrific talk and such an important topic, and we're deeply, deeply grateful. I wanted to just say to our colleagues on the phone, those of you who have not been on these things before, you should see, I've just been signaled that you will be seeing on your screen an online survey. Please do complete this. We don't just talk about this or show it to you. We actually actively use it in the planning for these things going forward. And every one of the sessions for this year has been chosen in part on the basis of the answers we get to the online survey. So please let us know what you think and what you'd like to be seen so we can gear the program to your needs. I want to repeat our gratitude to 3 companies who made our sessions possible this year through their financial contributions: AbbVie Corporation, Acadia Pharmaceuticals, and Lundbeck LLC for their very generous grants. Again, not connected with the content, but very, very gratefully accepted. I want to also alert you to the next session in our series. It'll be, as usual, a Tuesday, as usual, 1 p.m. Eastern United States time, Tuesday, March 8, and it will be on the subject of, I'm sorry, got that wrong, archive. I read the wrong thing. Please forgive me. The next session is going to be Tuesday, April 12th. It says April 12th here. Is it 5? Okay, sorry, we changed here. A little bit of confusion here, but we'll straighten it out. Tuesday, April 5, 2016. Tuesday, April 5. Apologies for my error. From 1 p.m. to 2 p.m. Eastern Time, United States time. The topic is going to be what's in the pipeline for Parkinson's treatments, gene and cell therapies. Roger Barker, who's a professor of clinical neuroscience and a consultant in neurology at the University of Cambridge from Britain, will be giving this talk. And I think you will all find it very, very interesting. He's a terrific guy, very, very knowledgeable, and we're thrilled to have him continuing the high tradition that Dr. Goldman has shown you today. So please put that on your calendars. I think that's about it. Did I miss anything, ladies? People are applauding, silently applauding, apparently. We don't get to hear you doing it with the usual clapping of hands and howling of compliments of that kind, but we're certainly seeing it online, and it all means the same, and we're very, very grateful. Thank you, Dr. Goldman, for your terrific leadership of this session. Thank you all for joining us today. Keep your questions coming. Our helpline people, I'm afraid, are going to be very busy for the next day or so looking at these questions, and we'll do our best to answer them in very, very short order. Thanks again, and see you, or should I say hear you, on Tuesday, April 5th for our next session. Thanks a lot. Have a good day and a good week. Bye-bye.